If you're listening to this podcast, you already know bladder leaks are common. But living with discomfort? That's optional. Attention Grace was created for bodies that deserve better. Our pads and liners are ultra-soft, highly absorbent, and made without fragrances, dyes, or bleaches, so nothing comes between you and your comfort. They keep you dry, control odor, and are gentle on sensitive skin, so you can move through your day with confidence. Shop at attentiongrace.com. That's ATTNgrace.com, and use code NAFC10 for $10 off your first order. Also available at select retailers nationwide. Attention Grace. Protection that cares for your body.
Welcome to Life Without Leaks, a podcast by the National Association for Continence. NAFC is America's leading advocate for people with bladder and bowel conditions, with resources, connections to doctors, and a welcoming community of patients, physicians, and caregivers, all available at nafc.org.
Welcome back to another episode of Life Without Leaks. I'm your host, Bruce Cassover, and joining us, as always, is Sarah Jenkins, the Executive Director for the National Association for Continence. Welcome, Sarah.
Thank you, Bruce.
Yeah, today's guest is a friend of the podcast. It's Dr. Ryan O'Leary, and you may remember him. We spoke recently about bowel urgency, and today we're going to be talking a little bit more in detail about IBD in particular. But before we did a little bit about Dr. O'Leary, he grew up in South Carolina before moving to Indiana, where he studied economics at the University of Notre Dame. But then he's returned to South Carolina to pursue a career in medicine. He completed his medical school and his internal medicine residency at the Medical University of South Carolina before starting as the Advanced Fellow in Inflammatory Bowel Disease for the most recent academic year. And he really is committed to delivering, compassionate, personalized care to help patients really navigate the challenges of IBD and Crohn's and colitis. So welcome, Dr. O'Leary. Thank you for joining us again.
Thank you so much for having me, Bruce. I'm excited to be back.
Yeah, we're excited to have you because last time we started talking a little bit in detail about IBD, but we really wanted to focus on bowel urgency, and that's a little bit broader. We're hoping we can learn, and you can help us learn, a little bit more specifically about IBD. So I'm wondering if you could sort of define IBD for us so that we can understand it as a distinct condition that's not just sort of some vague, have to go to the bathroom a lot type of thing.
Yeah, absolutely. Yeah, this is my favorite topic, so I'm very excited to be discussing IBD. So IBD stands for inflammatory bowel disease, and it encompasses two diseases. One is Crohn's disease, and the other is ulcerative colitis. And these are diseases that affect about 1% of the general population. And now patients can develop these diseases at any stage in life. Classically, we think of kind of two times of life that are most common to develop these diseases. The first kind of peak is in the late 20s, and the second can be in middle age, kind of 40s to 50s. But patients can develop these diseases at any time of life. So we have patients as young as 1 year old, and as old as patients in their 90s, 80s, and 90s. So it's ulcerative colitis and Crohn's disease, and they're chronic inflammatory bowel conditions of the bowel. And they can affect, ulcerative colitis tends to only affect the colon or the large bowel, and it can affect different extents. So in some patients, it just affects the rectum. In other patients, it affects the entire large bowel. And then Crohn's disease classically can affect any of the part of the bowel from the mouth to the anus. And there's overlapping treatments for the diseases, but there are some medicines that can only be used for one disease. And the diseases have an overlap in symptoms, and this can include a variety of things from diarrhea, abdominal pain, weight loss, blood in the stools, and even some upper GI symptoms, nausea and vomiting. So they're very interesting diseases, and it's what I do. It's what I do for work. So I do it every day, and I love taking care of these patients.
Yeah, that's great. And I'm sure that they appreciate all the help and service that you provide to them. One thing I wanted to ask that you mentioned is that there's these two kind of age ranges where patients can be diagnosed.
Mm-hmm.
What are the challenges with each one? I mean, it's a hard diagnosis for anyone, but I can imagine being a younger individual and receiving this might present its own unique challenges versus someone who's a little bit later in life. Do you have any insights or stories about that?
Yeah, certainly. Certainly. So in our younger patients with IBD, the FDA has a variety of medicines that are approved for IBD, and there's certain ones that are only approved in adults. And so that's, I think, one of the first challenges of our pediatric patients with IBD is you have less kind of available medicines to you. In general, young patients with IBD tend to have more severe manifestations. And so that's another thing to note too. And then there's unique challenges in our older population as well. Our older patients with IBD, we have to take a lot of things into consideration when managing their IBD. Like they tend to have other medical problems that can complicate their IBD. And then we also know that older patients with IBD tend to be at higher risk for infectious complications with some of our medicines. So we have to be very mindful about the patient's age and kind of coming up with a personalized treatment plan for their IBD.
Yeah, I can imagine that can be really difficult. So what are the percentages? I think you said that younger people, they tend to be diagnosed more than when you're older. So what's the breakout of that? Do you know?
Yeah, I don't know, not sure about the exact numbers, but in general, we think of a bimodal distribution, meaning that if you look over a lifespan, there's kind of two peaks in the incidence of IBD. The first one kind of being like around like the 20s, the second decade of life, and the second peak or increased time of prevalence is in middle age.
Mm-hmm. Okay. So I can imagine that pediatric patients who are diagnosed probably are excited actually to get to the point where they can use some of these meds that can make a real difference for them.
Yeah, definitely. And that's another really important thing in the IBD world is the transition of care. Because a lot of patients that are diagnosed when they're children will, eventually, since it's a chronic condition, they'll eventually graduate to coming to our clinic where we take care of adult patients. And so that transition is very important too.
Can you talk a little bit about what that looks like?
Yeah, I mean, I think one of the things that we talked about is that there's more medicine options for the adult patients, and then another kind of aspect of that is us having a good handoff with the patient's pediatric gastroenterologist. So understanding as much as we can about their disease course, about their prior treatment history, about if they've had complications related to their IBD. So it's very important that we have a good, transition of care to the pediatric world. And I think another thing that can be challenging for patients that were diagnosed young is transitioning from pediatric care. A lot of them will have their parents very involved in their care. And then when they come to the adult world, they're going off to college, they're getting jobs, they're becoming more independent. And I think with that comes kind of an ownership of taking care of their own health and like understanding living with IBD and taking care of their own medicines. And I think that's a really important part of the transition too.
Yeah, that brings a whole nother meaning to just growing up, right?
Yeah, exactly.
Related to that, you were talking about how it's a chronic condition and, you could have it for, a lifelong. Maybe I'm wondering, is it something that can be cured? Is there an endpoint for some people, or is this something that people will just have to learn to manage for the rest of their lives?
Yeah. Unfortunately, we don't have a cure yet for inflammatory bowel disease. There's certainly been a lot of development and a lot of research on the prevention of inflammatory bowel disease and understanding the factors that may lead to these diseases developing. And so there's been a variety of research on anything from like the microbiome, which is the kind of natural flora or bacteria that live in our gut, to diet, to they've studied to see if life stressors or certain, exposures can lead to the development of these diseases. So lots of research on the prevention of it, but unfortunately not yet a cure for patients.
So what is science telling us are the likely sort of culprits behind some of this then? Do we have had pretty good leads?
Yeah, I mean, they've studied it. They've studied a lot of different things. So diet has been an area of particular interest, and it's difficult it's difficult developing studies on diet. They have to look at large cohorts like of patients and try to study dietary patterns like on the country or like the very large scale level. And so there's been some developments in risk factors for developing IBD. For example, they've found that patients with low levels of fiber in their diet have higher levels or higher risk of developing IBD, or patients that populations that eat more red meats are at higher risk of developing IBD. There's been a lot of studies on the microbiome, and if is there a certain kind of signature or type of bacteria or combination of bacteria that can lead to IBD. And that's we're not sure. It's an area of kind of like active research. And we know that the time period before a patient develops IBD, they'll have a distinct change in their microbiome or the bacteria living in their gut. And so that's been an area of interest for a lot of people in the prevention of IBD. And then we do know that, if you have a family member or a direct relative that has one of these conditions, Crohn's or ulcerative colitis, that you're at higher risk for developing IBD. So it's a complex interplay of our body's immune system, the microbiome, exposures, and genetics in our family history.
That makes a lot of sense. And I'm sure that, people are actively working on trying to, get to the bottom of this. So if I go in, though, for treatment, what are the realistic goals for treatment today? What sort of can I be hoping for?
Yeah, so our first goal of treatment is we want a patient to feel better. And so the vast majority of patients with IBD are diagnosed after they develop symptoms. And it can be a variety of symptoms like kind of discussed earlier. So it could be unexplained weight loss, diarrhea, loose stools, fecal incontinence, waking up at night to have bowel movements, blood in stools. Patients with Crohn's disease can have complications called fistulas, which are kind of abnormal tunnels from part of the GI tract. And so that can lead to symptoms like having kind of drainage by the perirectal area. And so there's a variety of symptoms, kind of GI. And the interesting thing about IBD is there's also something called extraintestinal manifestations, which can encompass a variety of organ systems. So patients can have distinct rashes that are related to IBD. They can have eye manifestations that are related to their IBD. And they can even have things like worsening of joint pains. We call this like IBD-associated arthropathy. So it's a variety of symptoms. And so that's our first goal of treatment, is getting your symptoms better, because the vast majority of IBD patients are symptomatic. So that's goal one. And for the vast majority of our patients, we can get them great relief with our current medicines in our toolbox. And then the second goal of treatment in IBD is inflammatory bowel disease is an inflammatory condition. So when you do a colonoscopy or you take a look at the GI tract from the inside, you'll see inflammation of different parts of the GI tract. And that's our second goal of treatment, is to reduce or eliminate that inflammation. And we call that remission. So we want a patient to be in clinical remission or in symptomatic remission, meaning their symptoms are better. And then we also want them to be in endoscopic remission, meaning when you do colonoscopy, the area of the GI tract that is affected by IBD is healed. And the reason that's important is we know that patients, when they have healing from the inside of their GI tract, they're less likely to develop complications from their IBD, like needing surgery. There's an increased risk of colon cancer in some of our IBD patients. And so that is the second kind of component of our goals of treatment.
And is it realistic to think that you can enter into a period of remission for a long period of time?
It is. Yeah, we certainly had patients that are in remission for years and even decades. And the challenging thing with IBD is every patient is different. And I think it's one of the exciting things as a clinician is you really have to treat the patient as an individual. And so one medicine that works for one patient may not work for another patient. And for some patients, the first medicine works great and they'll be in remission for years. or even decades. And for some other patients, the first medicine doesn't work well and they have to try different medicines. So the disease course is unique for everyone, but we certainly have a variety of patients that we see in clinic that we see once a year that have been doing really well on a single medicine for years.
I wanted to ask you about medications because it seems like if you were to take away pharmaceutical advertising from television, the entire media world would collapse because every second commercial is something for somebody with Crohn's or ulcerative colitis or something. What sort of medications are available today?
Yeah, so like you said, there's a variety of medicines. Just turning on the television, you'll see a couple. So we know the first thing when choosing a medicine that's right for the patient, the first thing is, there's a lot of things that we take into consideration. So first is the severity of their IBD. And we kind of grade that. There's different grading scales that are based off objective measures and patient symptoms. And so we grade that into mild, moderate, or severe. And we treat patients with, with severe disease different than we treat patients with mild disease. So to take ulcerative colitis, for example, there's some patients that have such severe disease that they're getting hospitalized, that they're needing IV steroids. And that's a very different situation than a patient with ulcerative colitis that has mild disease in the rectum that can do very well as an outpatient with medicines that we call mesalamine type medicines. So first we understand, we have to think of what the severity of their disease is. And now for patients with more severe disease, there's a variety of tools in our toolbox now. So there are medicines called biologic medicines or small molecules that have revolutionized the way that we treat IBD. So the first medicine that came around that many people know of is infliximab, or people know the generic name Remicade, and it came out in 1998 for IBD. And we still use infliximab quite a lot, but now our tools in our toolbox has expanded dramatically. So infliximab, for the most part, is IV formulation, but now we have medicines that are pills that patients take every day to control their IBD. Some are subcutaneous shots that they take every couple of weeks or sometimes every 8 weeks to control their IBD. And so we take a lot of things into consideration: patient preference for the route, their disease, and also some of their underlying medical problems. Because sometimes these medicines can help other conditions if they have comorbid autoimmune conditions like rheumatoid arthritis or psoriasis. So we have lots of treatments options for patients, and the first one works for some patients and doesn't for others. But the great thing is we have so many tools in our toolbox now.
That's very encouraging. I love hearing that. But I think we all know that sometimes medication, all the different types of medications, they are not always successful for the same person. Or somebody may have a condition that is more advanced than medication can handle. So beyond medications, what sort of treatments might a patient encounter?
Yeah. So, a lot of our patients ask us about diet because I think there's a lot of patients that are interested on making dietary interventions to try to control their IBD. And what the research shows and what we recommend for most of our patients is eating in a Mediterranean type dietary pattern. So it's something that has been studied in a variety of diseases ranging from cardiovascular disease to IBD. And that can certainly help as a healthy diet, but by itself cannot control the underlying IBD. Patients will ask about that. There's some kind of integrative or alternative medicine options for IBD that have shown some efficacy in IBD. Curcumin is one of them in ulcerative colitis that we use for some patients that are looking for medication-sparing strategies. And then a very important component in IBD care is also surgical interventions. So our goal of medicines is to try to avoid surgery and surgical interventions. But for the right patient, surgery can be very life-changing and can really help their symptoms tremendously. And so we work very closely with our colorectal surgeons on identifying patients that we think could benefit from surgery. And there's a subset of patients that fail medical therapy that really surgery can be quite life-changing and life-saving.
would imagine that, considering how life limiting it can be to have, one of these conditions, that your surgery, if that's your only option, it really could, restore a lot of the freedom and confidence that you didn't have before. But
Mhm.
I think one of the challenges is that I don't want to see you. And I think a lot of people don't want to see you because the idea of having to go and talk to a stranger about all this embarrassing stuff
Yeah.
and potentially have to face things like surgery is just a terrible idea. And I'd rather suffer. Now, certainly people who are, whose conditions are so bad that, they can't go out of the house, et cetera, they'll come to you because they have no other choice. But for somebody whose symptoms might not be quite so extreme, what can you say to help me realize that, yeah, I really should go see a doctor?
Yeah, yes. I think first off is we love taking care of IBD patients, and at MUSC we have something called an IBD medical home, and what that means is that we're here for you. Like we treat patients as family. So if when they come to a visit, they see a variety of team members. They see friendly nurses. They see me, a fellow, other doctors. We have them talk to our social worker that helps them with the kind of psychosocial component of IBD. And so while some patients that are new to IBD are understandably hesitant to talk about a sensitive topic, such as like bowel habits and things, once they start to get to know us, like they really, I think, appreciate coming to us. And so I would say that it can be tough at first, but we're really here to support you in any way we can. And sometimes or oftentimes we help patients even with non-GI related issues. So I would say that, that we're here to support you. And then another thing that I would say is, if you're in the camp of mild symptoms, I would say there's a subset of patients with IBD that have like kind of silent IBD. So particularly in patients with Crohn's disease of like the small bowel or the ileum, they can be less symptomatic, but there can be kind of severe inflammation going on without severe symptoms. So I think it's very important for patients to be proactive about treating their IBD. So even if they're feeling well now, we want to follow them closely and we want to control their disease so we can prevent complications from occurring in the future.
That's really interesting. When you take into account that you could have a silent condition or you could have those other manifestations like eyes and joints and things, it really sounds like it's not the sort of thing, even if you're having, bowel issues, that you could diagnose yourself. You really do have to have a professional diagnosis. Is that fair to say?
Yeah, certainly. IBD is such a difficult disease to diagnose because it's not as simple as like a blood test or an image. You have to take so many things into consideration, including patient symptoms, blood tests, imaging, colonoscopy. So it really takes an expert to diagnose and to treat these conditions.
So I have another question just following that. We hear and have talked to patients about how long it does take to receive a diagnosis because of all the reasons you just said, that it could be a number of different symptoms that presents differently in everyone. What would your advice be to someone who is really struggling and is experiencing some of these symptoms, but is still struggling to get a diagnosis?
Yeah, I mean, it's definitely a common situation that we see. The patient that has kind of suffered from GI complaints for years before coming to a diagnosis. And it can be a challenging diagnosis to come to. And oftentimes patients can be misdiagnosed before. They can be diagnosed as irritable bowel syndrome, which is a non-inflammatory condition of the gut that is quite common and much more common than IBD. So I would say, for a patient that's kind of hasn't yet had a diagnosis, I would continue, seeing your doctor. I think it's fine. I think you should be persistent. I think getting a diagnosis can be can give a patient a lot of relief. Because then you can learn about your disease, you can get on proper treatment. So I would say, continuing to see your doctor, and it's also fine to get a second opinion or to see another doctor. And certainly something that we encourage from, patients that are kind of struggling to get what they feel like is a proper diagnosis.
Yeah. And if they haven't gotten a referral to a specialist, it sounds like that's something that they should also push for to really get those more expensive tests done and hopefully a quicker time to actually getting a diagnosis.
Definitely.
Great.
There's a question I wanted to ask, and I know this is probably going to sound like a dumb question, but from a medical perspective, could you tell us what exactly is inflammation in the first place?
Yeah, inflammation. So inflammation, it involves our immune system. So our immune system is made up with a variety of different cells. And it's essentially the point of the immune system is to identify self versus non-self. So self being your own body, your own body's organ systems, and non-self being like an infection or a bacterial infection or something that your body should mount against. And so the way that inflammatory bowel disease develops, and one of the kind of mechanisms behind it, is the body is recognizing the parts of the GI tract as non-self, and it is mounting a inflammatory response against our own body and our own organs. And so that involves kind of certain molecules called interleukins, which are like cell parts of the immune system that kind of attack our own body's like GI tract and GI system. And so the basis behind a lot of the medicines that we use that we discussed earlier, like the biologic medicines and the small molecules, is they interact with our body's immune system to try to block that response in different pathways, different steps of it. So that's kind of, what it means to have an inflammatory condition and like what is kind of going on in a patient with IBD.
And I guess that's why you have those all sorts of what might seem like unrelated manifestations are actually sort of all different symptoms of inflammation.
Certainly.
And I guess that's also why the same medication might treat other things that you don't even realize it's going to be treating when you're taking it.
Right, exactly. And it's also the proposed mechanism behind why patients with IBD are more likely to have like depression and anxiety, because, those conditions are also, there's also a hypothesis that they're related to inflammatory conditions in our body's own immune dysregulation. So it's I think is certainly the explanation behind the IBD itself, and then what we call the extraintestinal manifestations of IBD.
Well, that's really interesting. Although I'd imagine that the symptoms alone are probably enough to cause depression. And we know that patients are often, they do often have to struggle with, self-image and things like that. If the inflammation itself only compounds things, that's going to make it particularly difficult to deal with it from a mental health perspective.
Certainly. And it's something we see commonly in our patients. I think, like you said, part of it is like struggling with living with a chronic condition and the impact that has on your life, be it work, like personal relationships, like studies. And so that's certainly a component of it. Another component is like the inflammatory response, and like that being tied to like depression and anxiety. And it's a very important thing that we ask our patients about and that we treat as well, like through a variety of mechanisms. We obviously want to get the IBD under control and the inflammation under control, but we also really support patients in going to see counseling and trying medicines for depression and anxiety. And this kind of multimodal approach is patients really appreciate it, and they have great outcomes with it as well.
Well, great outcomes is what it's all about. So I'm really glad to hear that. And as you know, from past experience, this is Life Without Leaks. It's a podcast about helping people live a life without the challenges of incontinence. And we always like to leave our listeners with one little hint, tip, strategy, bit of advice for them to live a life without leaks. So maybe you have one you can share with us today for those who are struggling right now with IBD or a similar condition.
Yeah, certainly. So, if I were to leave you with one message, is that there's really hope in getting your IBD under control. So living with IBD it's a windy road of ups and downs, and our team is here to help you with that, to support you through that, and that, patients really live very full and flourishing lives with IBD. And that's where most of our patients are, but we also are here to help you through the down times. But there's great hope, and that we're continuing to learn more about the disease and how to prevent, treat it, and hopefully one day cure it.
Well, that's really encouraging to hear, and I hope that our listeners take it to heart. So thank you very much for sharing your insight and for joining us today.
Yeah, thank you so much, Bruce and Sarah. I enjoyed it.
Life Without Leaks has been brought to you by the National Association for Continence. Our music is Rainbows by Kevin MacLeod. More information about NAFC is available online at nafc.org.